This conference will now be recorded.
Slides between 49, 59 is better. Renal cancer.
49 is
49, 53 ఉంది. ఇది పెరిగినప్పుడు గ్యాప్ చేస్తుంది కదా పెట్టాం. హలో హలో హలో.
Yes, sir.
Today I will discuss about some pathological conditions of the kidney and followed by the renal calculi. Okay. Last class we have covered only half of the infectious conditions of the kidney. So 2 or 3 are there: carbuncle, perinephric abscess, and pyonephrosis. So commonly they can ask as a short notes. You need to know something about these things first. Okay. Followed by the renal calculi. So pyonephrosis. So previously we have discussed about the hydronephrosis. Now we are talking about the pyonephrosis. What is the definition of the pyonephrosis? Hello?
Yes, sir.
Are you
Audible,
hearing
sir.
me? I am Dr. Rambabu speaking. Okay. So
Yes, sir.
pyonephrosis, sometimes they may ask as a short notes. You should write something about the pyonephrosis. So what is the meaning of pyonephrosis? Pyo means pus. So there is a collection of pus present in the pelvic calcium system, which is converted into a multiloculated sac. So the pus in the kidney or renal parenchyma is known as the pyonephrosis. So what are the causes for the development of pyonephrosis? One is the infection. Pre-existing hydronephrosis can be converted, get infection may produce pyonephrosis, or any acute pyelonephritis. Any inflammation of the kidney, acute condition of the kidney may sometimes may produce some collection of pus in the renal parenchyma. The third one is the complication of renal calculus, either in the renal pelvis or Staghorn calculus. Staghorn calculus means the entire kidney may studded with the all renal papillae or studded with the stone, that is called Staghorn calculus. So these are the common causes for the pyonephrosis. One is the pre-existing infection of the hydronephrosis, followed by the acute pyelonephritis, or any renal calculi may likely to lead to the formation of pus in the kidney. So once the patient has developed the pyonephrosis, what are the clinical features patient may have? Usually it is a unilateral. Only one side of the kidney may be affected. So when you examine the patient, there is a tender mass present in the groin or loin. That is a smooth in color, smooth surface, soft in consistency, not mobile, but not moving in the respiration. Why? Because some inflammation is there. Perinephric region may attach to the surrounding structures, so that it may not be mobile as like a normal kidney. So that is the, when you examine that loin, there is a mass present, palpable, that is a tender. The mass is a smooth, soft, and not mobile, not moving in the respiration. Okay. Next, patient may have a cystitis. There is a infection of the urinary bladder. Some pyuria, pus may passes through the urine. Pyuria. Patient may have a burning micturition. These are all due to the sort of some enterobacterial infection. Next, if it is so severe, patient may go into the stage of toxicity fevers, manifestation like fever, chills, and rigors. If you are not going to treat in time, patient may go into the stage of toxicity. So patient may have a shock and fever with chills and rigors. So how do you investigate the pyonephrosis? You should take a plain X-ray of the abdomen, including the both kidney, urinary, bladder. Sometimes there you can see the calicles in the either kidney or ureter or bladder. So that is also one of the responsible for the factor developed for the development of pyonephrosis. Next, if you take intravenous urography, shows poor secretion can be seen. The material will not go correctly into the kidney because of pus is there. Next, another investigation, cystoscopy. So what is the importance of the cystoscopy? You can identify the any inflammation within the bladder or cystitis. With sometimes you can see the uteric orifices on the trigone and the lateral aspect of the trigone of the bladder. You can able to see by doing cystoscopy. So when there is a pus in the kidney, sometimes it may come down to the ureter and may pour into the urinary bladder. So you can easily identify by the cystoscope. The next one is ultrasound. Ultrasound of the abdomen shows there is a dilatation of the kidney because of accumulation of the pus within the kidney parenchyma. Next, DTPA scan. DTPA scan is useful to know the functional status of the kidney. So these investigations to be done. DTPA means diamino triacetic pentaestic scan. So how do you treat this case? So once you diagnose as a pyonephrosis, you can start with the antibiotics. So if it is pyuria is there, you collect the urine and send it for culture and sensitivity, which organism is suitable for that, which organism is there, that is you can identify the culture and sensitivity, and you should give a proper antibiotic so that you can control the infection. Or you can get the pus either giving the nephrostomy tube, that calls carbostomy nephrostomy tube can also be placed in the kidney. So when the kidney is totally destroyed or spoiled, what you have to do? Subcapsular nephrectomy should be done. Sometimes the other kidney may be also get infected by the perinephric lymphatic connections. So you should also assess to the other kidney is going to be infected or not by doing some ultrasound of the abdomen. If it is in the case of bilateral pyonephrosis, what you have to do? Bilateral nephrostomy should be done. Nephrostomy means you can put a catheter into the kidney from the periphery to the kidney. Either Malcott's catheter or Foley's catheter may be placed into the kidney and to let out all the pus. That is called nephrostomy. Nephrostomy means making an opening from the pyonephrosis kidney and let out all the fluid pus. If it is present in the near to the ureter, you can put a stenting. J stenting should be done to drain the pus from the ureters. Next, another renal pathological condition is the carbuncle. So it is also known as the renal carbuncle. So what is the main cause for the formation of the carbuncle? So there is, what is the carbuncle? There is a localized inflammatory necrotic tissue of the kidney involving the renal parenchyma, mainly caused by the Staphylococcus aureus, certain coliform organisms like E. coli, Klebsiella, Proteus, like that. So what is the source of infection for the development of carbuncle? So patient may have a boil or carbuncle, especially it can be seen in the diabetic individuals. So that is the source of infection to develop the carbuncle. So this carbuncle is ill-defined. Borders are ill-defined. Next, tender swelling present in the loin associated with the pyrexia. If you do the total count, the leukocytes may be increased because of infection. The leukocytes count may be raised. Next, if we can culture the urine, we can isolate the staphylococcus organisms. So one of the Staphylococcus aureus is mainly responsible for the development of carbuncle of the kidney. You can isolate from the urine culture and give some proper antibiotics. Cultural sensitivity and antibiotic test you can done from the urine. Next, sometimes if you do intravenous urography or pylography, there is a obliteration of some group of calces, just like a renal cell carcinoma. So carbuncle can also be mimicked as a renal cell carcinoma. So you should avoid to know whether it is a carbuncle or renal cell carcinoma. If it is renal cell carcinoma, you have to go away with other treatment is different. You can do total nephrectomy. Only carbuncle it is there, you can do partial nephrectomy or so this is the diagram showing the carbuncle. Is this carbuncle cut section shows the necrotic area and some areas of pus. The yellowish are pus. So commonly seen in diabetic individuals. So how you will treat this carbuncle? Should give antibiotics to drainage of that carbuncle by keeping a Malcott's catheter and give antibiotics. If necessary, it is so severe, then you should go for nephrectomy, upper pole partial nephrectomy or lower pole partial nephrectomy should be done. Sometimes a patient may go into the stage of renal failure. If it is septicemia, that infected material may enter into the bloodstream, may produce septicemia. So that you can think it of septicemia may also arise if you are not going to treat properly that carbuncle. Okay. Next, another pathological condition is the perinephric abscess. So, pyonephric abscess, carbuncle, and perinephric abscess. These are all infective stages of the kidney. Sometimes they may ask you short notes about the perinephric abscess. So, what are the causes for the perinephric abscess? So, already existing pyonephrosis is there. So, this capsule is ruptured, and some amount of pus may collected in the peripheric part of the kidney. That is called perinephric. Peri means outside of the or surrounding area of the kidney. So mainly it is due to the any perinephric hematoma. So subcapsular hematoma, small size subcapsular hematoma is there. This hematoma is not drained properly, that go into the stage of perinephric abscess. Next, I already told you there is a perforation of the renal capsule from the pyonephrosis or a renal carbuncle, that is also leads to the perinephric abscess. Next, tuberculosis. Suppose subcapsular hematoma is there. Some tuberculosis infection may have been taken place, may produce the tuberculous perinephric abscess. Next, this perinephric abscess may go into the cortical portion of the kidney. So that is extension of the cortical abscess. So whenever there is an abscess present in the cortical region of the kidney, that may extend into the perinephric region of the kidney, may produce the perinephric abscess. Okay. Next, it can also due to the hematogenous spread, or sometimes appendicular abscess. If you are not going to treat the appendicular abscess, so this abscess may closely related to the surrounding area of the kidney, may produce the perinephric abscess. Or periurethral lymphatic spread can also occur due to the development of the perinephric abscess. So how do you investigate this perinephric abscess? So you should do the total count. If you do the total count, all cells are increased. The total count may be raised in case of perinephric abscess. If you take an X-ray, plain X-ray of the KUB, a kidney urinary bladder, there is a obliteration of the Soyas shadows. Sometimes you can see the scoliosis in X-ray, and the affected side, the diaphragm is elevated. That is the elevation of the hemidiaphragm. So these are the X-ray findings. One is the obliteration of the shadow, Soyas shadow, scoliosis, and elevation of the diaphragm on the same side, hemidiaphragm, that is called. Half of the diaphragm is elevated because underneath the diaphragm there is a kidney. So once the perinephric abscess is there, it may push it upwards, that affected region. So there is a elevation of the hemidiaphragm. These can be, all these things can see in the case of plain X-ray. Next investigation is intravenous urography. So these two intravenous pyelography can be taken in the two positions. One is the lying down position, another is the erect posture, the standing position. So what are the things you can know by doing these two positions? So normally in a standing position, there is a downward displacement of the kidney is seen. Normally, if it is perinephric abscess, that may be obliterated. So downward displacement is not seen in perinephric abscess. That is called Matthys sign. Understand? Matthys sign, M-A-T-H-E-S. Matthys sign means when the perinephric abscess is there, there is a there should not be seen any downward displacement in the intravenous urography. That is called Matthys sign. The other investigation is the ultrasound of the abdomen. You can see the which part of the kidney is affected, upper pole or lower pole. You can easily identify. Next, ultimately CT scan. So how do you treat? The perinephric abscess should start with the antibiotics. Next, under GA, you should always approach the loin region and pus should be let out. It should be done under the general anesthesia. Should give a lumbar incision and pus should be drained adequately. And that pus should be sent for cultural sensitivity and give, after obtaining the report, you should give a proper antibiotics. The collection of the cortex of the kidney should also be obtained by giving this incision. Sometimes cortical abscess may also extend ending to the periphery of the kidney, may produce the perinephric abscess. So it is the pus present in the cortical region, and you can put a Malcott's catheter and to maintain the continuous drainage of the pus. That is also, this is the pattern of treatment for the perinephric abscess. Okay, we discussed about the pyonephrosis, carbuncle, and perinephric abscess. Now we have to discuss about the renal calculi. Sometimes they commonly ask the essay question: causes, etiology, pathogenesis, clinical features, and treatment of the renal calculi. So you should know in detail about the renal calculi. Okay, what are the etiological factors? So there are certain etiological factors responsible for the development of renal calculi, and you have to discuss in detail one by one. So what are the commonly causes? Diet. So when there is a deficiency of the vitamin A, when you consume the diet, it is not the lacking of the vitamin D, vitamin A deficiency may lead to the development of renal calculi. This is one of the etiological factors. Next, dehydration. In hot climates, dehydration can occur. So what happens once the dehydration has occurred, the urinary solutes are increased and colloids are decreased. So this is also leads to the formation of renal calculi. Understand? The dehydration is one of the cause. In that, the solutes means sodium chloride and all solutes may be increased and colloids are decreased in hot climate. Next, increased urinary citrate. So when the urinary citrate, normally 300 to 900 grams can be seen in the urine in 24 hours, but it may be increased or decreased. You should assess. If it is decreased, the urinary citrate may likely to develop the renal calculi. So one is the vitamin A deficiency, dehydration, decreased urinary citrate. Another is renal infection, just like in pyonephrosis or hydronephrosis are going to be infected, may likely to development of the stasis of the urine. So it may be also responsible for the development of renal calculi. Next, inadequate drainage of the urine. So suppose any ureteric injury is there, so the urinary output is not been there, so that there is a stasis of the urine. It may leads to renal calculi formation. Next, prolonged immobilization. So what happened in suppose any for example paralytic ileus patients or any major surgeries related to the hip joint surgeries like orthopedic surgeries, there is a prolonged immobilization may be required. In such conditions also there may be a chance of development of the renal calculi. So I will tell you what is the pathogenesis of each point in the next this one. So next, hyperparathyroidism. This is also hypercalciuria can occur, hypercalcemia. So there is increase in the calcium levels in hyperparathyroidism, that is also likely to the formation of renal calculi. Next, there are some theories are there, Randolph's plaque and macroliths. Suppose what is the pathogens? Suppose if the vitamin A deficiency is there, so there is a desquamation of the epithelium can occur in the renal parenchyma. That desquamated epithelium may act as a nidus for the stone formation. So that is the cause for the vitamin A deficiency. Suppose citrate. So I already discussed it in the dehydration in hot climates. What happened? Urinary solutes are increased and colloids are decreased. What happened? These urinary solutes are combined with the calcium and they produce the calcium phosphate stones. Next, decrease the level of this citrate. We already discussed at that point. So normally 300 to 900 milligrams per 24 hours. So this whenever there is a decreased citrate level, there is a chelation with the phosphate like calcium phosphate and calcium carbonate formats can occur, renal stones can occur. So decreased urinary citrate is likely to precipitate the calcium stone formation. There's certain infections in the kidney. So what are those? Especially urea splitting organisms. So the urea splitting organisms like E. coli, Staphylococci, Streptococci, Klebsiella, Proteus, all these are urea splitting organisms may likely to cause the stone formation. You can remember urea, E. coli, and SP means Staphylococci, Streptococci, and Proteus. You can easily remember that the urea splitting. Just a prolonged immobilization. Suppose paralytic patients or any orthopedic surgeries, major surgeries. What happened? So when there is a prolonged immobilization, there is a decalcification of bones from the bones. So this decalcification means the calcium is come out from the bony areas and produce the hypercalciuria. This hypercalciuria is likely to develop the stone formations. So decalcification can occur in the prolonged immobilization, that is also leads to the formation of renal calculi. Next, as I told you that hyperparathyroidism. So what happened? The calcium levels are increased in hyperparathyroidism, so that it may lead to hypercalciuria. So what happened? multiple stones may develop. So that is called nephrocalcinosis. Bilateral nephrocalcinosis means stones present in the kidney is called nephrocalcinosis. It may be bilateral usually. The other certain pathogens are hyperoxaluria. So hyperoxaluria can be seen as a result of glycine metabolism. When there is altered glycine metabolism, the oxalates can be developed, so it may reduce the oxalate stones. This is cystinuria, cystine, increase the cystine material. It is autosomal recessive. That means also responsible for the development of renal calculi. Next, urinary stasis. So, I already told you. So, inadequate urinary drainage. That means any obstruction in the ureter or ureteral injury likely to develop the stasis of the urine. So, that is responsible for the urinary renal calculi or obstruction of the urinary flow. Certain surrounding tumors are there, suppose in enlargement of the prostate or see a bladder or urinary stone may likely to develop urinary flow obstruction, so that it leads to urinary stasis that may leads to the formation of renal calculi. Now, the medullary sponge kidney, that is also one of the pathological condition of the kidney associated with the renal calculi. What is the Randolph's plaque theory? Carr's theory and Randolph's plaque theory are suggested that there is stone formation in the kidneys. What is that? What is Randolph's plaque? First, there is erosion can occur, but is due to the some stones, renal calculi in the renal papilloma, either cortex or medulla. The erosion can occur in this. This erosion can material may deposited in the associated with the urinary salts because of stages of the urine. It may combine with this erotic material. Urinary salts like sodium chloride and calcium phosphate may produce the renal stones. That is called Randolph's plaque theory. The third, the next one is the Carr's, CAR or Carr's theory, postulate theory. Here, what happened? The microliths are developed. A minute microliths are developed in the kidney itself. These are arised from the subendothelial part of the renal tubules. These renal tubules are carried out by these microliths are carried out by the lymphatics. When there is obstruction in the lymphatics, there is the microliths are enlarged and produces the stones. That is called Carr's postulation theory. So, what are the other certain systemic diseases or metabolic disorders? You should ask, you should know what are the metabolic disorders and likely to develop this sarcoidosis, gout, hypercalcemia, hypervitaminosis D, any neoplasms in the kidney treated, hypermagnesemia, magnesuria. These are all metabolic disorders may likely to develop the renal calculi. Next, renal tubercular acidosis. Renal tubercular acidosis may also responsible for the development of renal stones. Especially, you can see the calcium phosphates in renal tubular acidosis. Next, what are the various types of the renal kidney stones? There are so many varieties are there. Commonly, oxalates. So 70% of the stones are calcium oxalates. So what is the color of this calcium oxalates? The color is, it is also called mulberry stone. These stones are brown in color with the sharp projections. So brown and sharp projections are there. You can think it of, it is a oxalate or mulberry stone. Next type of the stones are phosphate stones. So only the incidence is 10 to 15%. These phosphates are either calcium phosphate or calcium phosphates are calcium, magnesium phosphate, ammonium phosphate. So these are smooth, white in color, whereas oxalates are brown in color. These are smooth in nature and white in color. So in alkaline urine, so these phosphates are rapidly increased, are enlarged, and fills the renal calyces and produces their shape, that is called Staghorn calculus. So Staghorn calculus commonly seen in alkaline urine because of calcium phosphates are filling all the renal calyces and produces the similar shape of the renal papillae. So that is called Staghorn calculus. When you take an X-ray, it is radio opaque. Next variety is the uric acid stones. So sometimes they ask you what are the radiolucent or radio opaque. Uric acid stones are radiolucent. Even if you take an X-ray, you cannot find out these stones in the X-ray. Whereas calcium phosphates and oxalate phosphates are able to see the opaque, radio opaque can be seen. So urinary stones or uric stones are only 5% the incidence. These are also smooth, hard and yellow in color. Multiple stones are there. These are radiolucent. You remember, very important. Radiolucent. You can very easily report U is there, lucently U is there, radiolucent. So you can remember very easily. Uric acid stones are present in the radiolucents. You should not get any confusion. Radiolucent U word is there, you can easily remember. Okay. Hello? Hello?
Yes, sir.
Understand? Radiolucent, you should never forget. U, radiolucent U word is there. That is uric acid. You can remember very easily. Okay, where you can see these uric acid stones? Commonly seen in gout, hyperuricemia, and purine metabolism. So in purine metabolism, commonly the uric acid stones are there. These are radiolucent. The other variety is urate stones, cystine stones. These cystine stones are very less common, only present in the cystinuria. So the cystine crystals are passed in the urine, that is called cystinuria. So this cystinuria is autosomal recessive, already discussed. It is arising from the renal tubules. So it's commonly seen in young individuals, young girls, and the urine is acidic. You can easily remember acidic, C is there. In alkyl, no C is there. Cystine in acidic urine. Sometimes entrance bit may ask you a multiple choice. Cystine stones are seen in alkaline urine or acidic urine. You can easily remember acidic, C is there. In acidic is also C is there. You can easily remember. So these cystine stones are multiple, soft in consistency and yellow in color, and this color may be changed to bluish color when exposed to the air. That is called greenish blue exchange can be seen in case of cystine. Sometimes it may attain the large size. It is also radio opaque. It contains the sulfur amount, sulfur material. So cystine stones are mostly containing of sulfur. So these stones are radio opaque, commonly seen in acidic urine. You remember some points. Acidic urine contains the sulfur, large in size, radio opaque, soft and yellow. So these are the characteristic features of the cystine stones. This xanthine stones. So where you have to see the xanthine stones? You remember it is a brick red in color. No other stone is color like this color. So xanthines are brick red in color. Oxalate stones are brown in color. Phosphates are white in color, like this. So each color carries its own specific color. So xanthin metabolism. So there is an alteration of the xanthin metabolism. The xanthin stones can be seen. They are red in color, red in color. This is due to xanthin oxidase enzyme deficiency. So whenever is a xanthin oxidase enzyme is deficit in the xanthin metabolism, may produce these xanthin stones. They are red in color, brick red. Next, indigo stones. They are blue in color. Indigo means blue. Indigo air flight is there, they are blue in color. So that you can easily remember. Indigo stones are blue in color. Next, striate stones. So these striate stones composed of magnesium, ammonium phosphates mixed with carbonates. So ammonium or magnesium phosphate combined with the carbonate is called stearate stone. It occurs in the presence of ammonia and urea splitting organisms like Proteus and Klebsiella. So these are various 8 varieties of the renal stones you can know. So stearate, indigo, xanthin, oxalates, phosphates, cysteine, and urate stones. So these are the 8 varieties of the renal stones. So the shape of the, you can also easily remember. Suppose if the calcium oxalate, it is a monohydrate or a dihydrate. If it is a dihydrate, it is a envelope shaped in color. If it is a monohydrate, dumbbell shaped in color. You can easily remember. Dumbbell means both sides. Dumbbell. So one side is a rod, middle is the rod, another is a nodule, another is a nodule, just like a dumbbell. So you can easily remember. Mono is dumbbell. Dihydrate is envelope color, envelope shaped. Uric acid are shapes are variable, either size and shape are variable, maybe either double or envelope or spiculated like that. Next, cysteine stones are hexagonal type. Triple stones are coffin type and coffin lid shape. So these are the various shapes. Based on this shapes, you can easily get diagnosed as a particular specific stones. Triple stone is a coffin lid color, shaped, cysteine are hexagonal shaped, and calcium oxalates are dihydrate calcium oxalate envelope shaped, and calcium monohydrate is dumbbell shaped. So these are the pictures showing this is the uric acid stones. Multiple stones are spiked like that. This is the calcium oxalates, brown in color, spicullates. The surface is a spicuous, projections are there. These are also cysteine stones, brown in color sometimes, yellow and brown. This is Staghorn calculus. Next, what is the stages for the stone formation? There are certain stages are there, development of the renal calculi. One is the supersaturation of the urinary solutes. Next, nucleus formation, crystallization, aggregation, matrix formation. Ultimately, stone has been developed. So these are the various stages of the stone formation. So first, initially supersaturation, nucleus formation, crystallization, aggregation, matrix formation, and stone formation. So what are the clinical features? When the patient is having renal calculi, patient may have a pain in the loin. Sometimes hematuria may be there. Pyuria may be there because of infection. Pyonephrosis may also leads to the development of stones formation. Pyuria can occur. Patient may have a fever or pyrexia. Urinary tract infection and burning micturition can be seen. If you palpate the renal angle, there is a tenderness and ill-defined mass can be palpated sometimes. Next, sometimes patient may have a renal hypertension. So pain, hematuria, pyuria, fever, urinary tract infection, tenderness in the renal angle or renal mass can be palpated. Sometimes renal hypertension can be seen. So how do you investigate this venous calculus? First, you have to blood culture, blood examination. So ESR should be raised because of certain sort of infection is there, staphylococcus, streptococcus, proteus infection. All these infections are more likely to increase the ESR. Next, even you can, blood should be examined for the some solutes like calcium phosphate or creatinine, blood urea, uric acid, and parathyroid hormone levels. All these things should be examined in the blood samples. Next, urine collection, urine examination. So urine also certain solutes are there, calcium, urates, cysteine are there. You should easily recognized by the renal stones. The specific gravity of the urine also should know. Next, plain X-ray of the abdomen. I already told you the plain X-ray of the abdomen. Sometimes shadows, renal shadows are there. So 90% of the renal calculi are radio opaque, except uric acid. That is radiolucent. Next, intravenous urography. Why you have to do the intravenous urography? Sometimes this renal stones may obstruct and reduces the functional status of the kidney. So you should know the assessment of the functional status of the kidney by doing intravenous urography or retrograde pyelography. These are essential to know the functional status of the kidney. Next, ultrasound of the abdomen. So you can easily detect the stones where they are located in the ureter or renal parenchyma, whether it is a radiolucent or not. So all this information get by doing an ultrasound of the abdomen. Next, urinary analysis and cultural sensitivity, CT scan. These are all investigations to be done to identify whether the stone is there in the kidney or not. So this is the plain X-ray of the abdomen showing this renal calculi. So the multiple stones are present in this 1, 2, 3, 4, the right kidney, and the phosphate white stone is there in the kidney, oxalate stones in the urinary bladder. So plain X-ray of the abdomen is also very essential. The ultrasound can see the stone. This is the stone. Opaque, radio opaque can be seen. This is also CT scan showing the stone, white. So how do you treat? How do you will treat this kidney stones or renal stones or renal calculi or nephrocalcinosis? Everything you can call it as renal calculi or nephrocalcinosis. Like first PCNL. What is meant by PCNL? Sometimes they may ask you short notes, 2 months short notes. You should know. You should expand. What is that PCNL? Percutaneous nephrolithotomy. That means through the skin, enter into the kidney and remove the stones. That is called percutaneous nephrolithotomy, PCNL. So what are the indications for doing PCNL? One is stone size. If it is stone size 2.5 centimeters in size, you should go ahead with the PCNL procedure. Multiple stones are there, you can also do the PCNL. And when they are not responding to the ESLW, electroshockwave lithotripsy, they are not responded or not breakdown, you can do PCNL. There's certain complications like any hemorrhage is there, patient may have hematuria or kidney injury or perforation. In such conditions also, you should do PCNL. You see, this is the instrument doing the kidney and attaches the skin and attaches to this, enter into the renal cortex, medulla, and pelvis, renal pelvis. The stone is here. They are going to remove this. It's called percutaneous nephrolithotomy. So, percutaneous nephrolithotomy indication size is more than 2.5 centimeters, multiple stones, not respond to the ASLWA. But certain complications can occur: hemorrhage, injury, and perforation. So, this is the stages of the PCNL. The stage present in the stone in the pelvis, renal pelvis. So, they are approaching like this. This is the diagram showing to the stages of the renal calculi. Remove. That is called PCNL, percutaneous nephrolithotomy. Okay, sometimes they may ask you short notes. Next, ECLW also they can ask us 2 more short notes. You should know something about this. Extracorporeal shock wave lithotripsy. So it is not a ESLWL, extracorporeal shock wave lithotripsy. Here, certain electromagnetic shock waves can be used to pass through the renal tissue to the stone and crush and combat with this shock waves, then break down the renal calculi. So the shock waves can be produced with 2 seconds for 2 seconds. So minimum 1,000 shock waves to be given to each stone to break down and break down the renal calculi. Next, Dornier lithotripter. Suppose the stone is there inside of the ureter or in the renal pelvis, you can use this Dornier lithotripter. There is some specified device is there, that Dornier bag is introduced into that. I will show the diagram later. This is the ESLW shock wave therapy to be given. If the stone is there, it may go into the shock wave therapy and break down and come down to the inner bladder and flush out. This is the ESLW mechanism. What is the advantage of this ESLW? No anesthesia is required. It is a OP method, daycare procedure. You can do it under the at the level of the OP. It should be done only if the stone is less than 2 centimeters or well fragmented. More than 2.5 centimeters are there, you should do PCNL. Commonly, you can do for the odd stones, oxide stones are better eliminated by the ECLW. So, any hard stone or oxide stones can be removed by the ESLW, electroshock wave therapy. Sometimes in one sitting may not be sufficient. Sometimes you may do a number of sittings to repeat until to get the clear of the stones in the kidney. So ESLW. So if the ESLW, you already told you the indication of PCNL. If the failure of ESLW is there, you should go for PCNL. So what are the complications? So when you do the shock wave therapy, certain complications may develop. What are the complications? One is the renal hematuria. So small renal vessels may be damaged by doing that shock wave therapy. A patient may develop renal hematuria. Or sometimes the major vessels like renal vein or artery may be damaged, may produce severe hematuria. So while doing this ESLW, sometimes the surrounding structures may also be damaged, injured, like adrenal glands are there, and liver other bowels may be damaged. So the fragmented stones may be sometimes retained in the urine and it can be removed by the electroscope. So what are the contraindications for ESLW? So there are certain contraindications are there. When the pregnancy is there, you should not give ESLW. In the bleeding disorders like what is that, hemophilia, because already there is a hemophilia is there. When you use this thing, there may be some hematuria can occur, profuse hematuria. So any bleeding disorders like purpura or hemophilia, thrombocytopenic purpura, in such conditions should be contraindicated. And abdominal aneurysms is very dangerous. You should never do shockwave therapy. Suppose aneurysms are there, these may be going to be ruptured and produce the patient. You may lose the patient. The another contraindication is serum creatinine. If it is more than 3 milligrams, normally 1.2, 0.7 to 1.2 milligrams, but it is more than 3 milligrams are there, it should be contraindicated. And any sepsis should not be do ESLW. Okay. Next, conservative treatment. How do you conserve the treatment? Usually small minutes are there, renal calculi, 5 mmR, 4 mmR, 3 mmR, 2 mm. Variable sizes of the renal calculi are there in the kidney. You can be managed conservatively. You need not to go for any PCNL or shockwave therapy. So you should give flush therapy. Flush therapy means intravenous fluid should be given, followed by the furosemide. Diuretic should be given to enhance the urinary flow. So 60 to 80 milligrams of furosemide means diuretic given intravenously. So increases the renal perfusion. So that certain small stones may be come out. This patient may have pain. In such conditions, you should give some anti-inflammatory drugs or antispasmodic drugs to be given to relieve the pain. So surgical management is there, non-surgical management is there. Next, what are the surgical managements? There are certain surgical procedures you should know. One is the pyelolithotomy. That means you directly open the kidney and remove the stone from the kidney surface. Kidney. That is called pyelo. Pyelo means kidney. Lithotomy means removal of the stone. Pyelolithotomy. Extended pyelolithotomy. Suppose only in the renal pelvis. Sometimes it may present in the pelvic junction. That is called pyelolithotomy. You have to extend the pelvis up to the pelvic junction. That is called extended pyelolithotomy. And nephrolithotomy, only within the parenchyma, either cortex or medulla. If you remove the kidney stones, that is called nephrolithotomy. Nephropylolithotomy, that means the junction between the cortex and the pelvis, renal pelvis. That is called nephropylolithotomy. It commonly done in the Staghorn calculus because that is a big calculus, may extend the entire kidney and may extend up to the pelvis to ureter. So in such conditions called nephropylolithotomy. And partial nephrectomy. If it is a one pole is there, big stone is damaged, then should do remove that part. That is called partial nephrectomy. Not going to total nephrectomy. That is called some part of damaged kidney to be removed. That is called partial nephrectomy. So understand very easily. Pyelo means kidney. Lithotomy means removal of the kidney. Pyelolithotomy. Extended pyelolithotomy I described. Nephrolithotomy means any renal calculus present in the calycis, the renal parenchyma or medullary region. Or nephrolithotomy means both pelvis and the parenchyma. Partial nephrectomy. These are the surgical procedures. You see here, you see pyelolithotomy. This is only in the renal pelvis. You can read pyelolithotomy. Extended pyelolithotomy. This is extended pyelolithotomy. So nephrolithotomy and kidney and the pelvis. Nephrolithotomy. This is also nephrolithotomy through the approach to the kidney. Nephrolithotomy. So partial nephrectomy and coagulum of the pyelolithotomy. So these are the diagrams showing the easily. Pyelo means pelvis, pelvic part, renal pelvis. Just bench surgery. This is also one kind of surgery is there. What is when bench surgery? What you will do here? The kidney is removed totally from the loin and cool it by ice packs or liquid nitrogen. So what happened once the kidney is cooled with the certain solutions like liquid nitrogen or ice packs, the stones are softened and remove the stones from the completely kidney, and later the kidney is placed in the anastomosis tubula. It is called bench surgery. This coagulation pyelolithotomy means we can remove from the renal pelvis. Next, anatropic pyelolithotomy. Anatropic. That is all the conditions where the stones present in the renal pelvis. So these are the various surgical procedures like pyelolithotomy, nephrolithotomy, extended pyelolithotomy, nephrolithotomy, partial nephrectomy, breech surgery, vein surgery, and coagulum pyelolithotomy, anatropic pyelolithotomy. These are the surgical procedures for the removal of the stones. Next, kidney stones are over. This is the last chapter for this. You should know something about the urinary calculi. Shall I continue? Hello?
Sir, next class. Wait, sir.
Next class. What class you have next?
Medicine, sir.
Medicine. Okay, time is over. So you will next class you will discuss about the urinary calculi and finish that chapter. So mostly
Yes.
the entire chapter to be covered. This is the last urinary calculi. You will coming into the next class. Okay. So renal
Okay.
chapter sometimes you may get some questions. So you should read thoroughly the chapter. Okay. This is the last item for the closing the session of that related to the kidney. Okay, we will discuss in the next class. Okay.
Okay, sir.
సార్ నేను నరేంద్ర మాట్లాడుతున్నాను సార్. సార్ ఇప్పుడు క్లాస్ ఏమైనా జరుగుతుందా సార్? ఇప్పుడు అయిపోయింది సార్. ఇప్పుడు చలపతిలో సార్ దగ్గర క్లాసు పీపీటీ ప్లే చేస్తాను సార్. ఓకే సార్. ఇంకా మీకు ఐడి అయితే పంపిస్తాను. ఐడి ఏం పంపించలేదు కదా సార్ రాజేష్ గారు? ఓకే, నేను ఐడి పెట్టి పంపిస్తాను సార్. పంపించాను ప్లే చేస్తాను సార్ ఒక భాగంలో. ఓకే సార్, థ్యాంక్ యూ సార్.